Hi all, and welcome to another session of vertical integration, which we have started with specific focus to MBBS students. Today's topic is on systemic hypertension, and for the discussion we have a very eminent panel. First, let me introduce the panel to you. To my left, we have Dr. Girish Kumar sir, Principal and Professor at the School of Medicine. Dr. Lakshmi from the Department of Pharmacology, and also Dr. Lalitambika Madam from the Department of Physiology. So we'll be following the same usual pattern of questions. And to start with, I will start with Lalitambika Madam. Madam, how will you define normal blood pressure, and what are the factors which usually contribute to maintaining of blood pressure?
Blood pressure actually is defined as the lateral pressure exerted by a contained column of blood on the walls of the blood vessels. So you have the walls of the blood vessels and the blood is there inside and it is exerting a pressure on the walls.
Yes.
That is what is normal blood pressure.
Okay.
And the factors that contribute to the maintenance of blood pressure, mainly there are two factors, cardiac output and peripheral resistance. There are also other factors like viscosity of the blood, the total blood volume and elasticity of the blood vessel, which also maintain the BP.
Right.
But normally in day-to-day thing, if you see, only the cardiac output and peripheral resistance show much variation. Because your total blood volume, normally it's 5 liters and it is going to be 5 liters unless you have something like you are taking IV fluids or you are having hemorrhage or something, bleeding, that is reducing the total blood volume.
Right.
And elasticity also, except in old age, there are not much differences in the elasticity or day-to-day variation is not there.
Right.
And viscosity also is the same because it is by the blood cells and the plasma proteins. So mainly when we concentrate on cardiac output and peripheral resistance, this cardiac output is the amount of blood ejected from each ventricle per minute into the circulation.
Okay.
And it is 5 liters per minute. And this cardiac output depends on mainly on the preload of the heart.
Right.
The end diastolic volume. The more the end diastolic volume, more blood will be ejected from the heart.
Yes, ma'am.
And this cardiac output is what mainly determines what is called the systolic blood pressure. Systolic blood pressure is the maximum pressure during systole of the heart. And there is the peripheral resistance, which is also an important factor. It contributes to what is called the afterload of the heart.
Right.
So greater the peripheral resistance, greater the load against which the blood has to be pumped. So afterload is the force acting on the heart after it begins its contraction. And this peripheral resistance depends mainly on two factors. One is the viscosity of the blood, the other one is the diameter of the blood vessels.
Okay.
The diameter of the blood vessel contributes too much to the peripheral resistance because resistance is inversely proportional to 1 by R4. That is 4 times the radius, inversely proportional to 4 times the radius of the blood vessel. So even a minor change in the blood vessel will affect the resistance very much.
Right.
And peripheral resistance mainly determines the diastolic blood pressure.
Okay, ma'am. But, so since we have cleared the normal part now, I'll move on to Girish sir. So what is the cutoff beyond which we will say that it is hypertension?
So if you follow up the hypertensive guidelines, what we understand is previously it was hypertension means above 120 and 80. But recent guidelines, JNC 7 onwards, JNC 7, 8 and onwards, what they are telling is less than 120, less than 80 is normal. That means 120, 80 is hypertension. Actually, in clinical practice, it is not correct that 120, 80 is not a hypertensive patient. It has created a lot of panic among a lot of doctors and patients because 120, 80 has now become hypertensive patient. Okay. It is not like that. In our clinical practice, what we know is 120, 80 is not a hypertensive, but something above 120 and 80 can be considered as hypertension in our clinical practice. Okay. Some patients you can see elderly individuals like 120, 80 is the hypertensive cutoff what we read in various guidelines. But some elderly individuals, if you see the BP systolic BP may be slightly elevated. Maybe because of, like Madam told, their blood vessels are thick. That has created some falsely elevated BP for like that type of patients. Arteriosclerosis. Maybe their BP may be 140, 80. Even then, according to the guideline, it is hypertension. Actually, they don't have hypertension. So to know the exact BP, we need to put a arterial line. Then only we can see what is their BP. But for a general guideline purpose, whatever the BP above 120/80 should be considered as hypertensive patient, and that too single reading will never tell you that this patient is hypertensive. Suppose you run half an hour or you do some heavy exercise, your BP may be slightly higher. That is only one point it is higher, but if you are taking 2-3 readings on the same day or repeated readings on different days, suppose the patient is anxious, BP can increase. All these things we have to rule out. Okay, 2-3 readings are required, continuously BP should be elevated more than 120/80, then only we can brand that patient as a hypertensive patient. So for all practical purposes, now we can see that above 120/80 is considered as hypertensive, but major guidelines like JNC 8, 7, 8 and all, they tell that less than 120/80 is normal. 120/80, there is no clear guidelines whether they are hypertensive or not hypertensive, but practical purpose it is normal only.
I'll come back to Lamia madam. Madam, can you tell in brief about the renin-angiotensin mechanism and how it influences the BP control?
This renin-angiotensin aldosterone mechanism, also called the RAS mechanism, is a very important mechanism because it acts by adjusting the blood volume and thereby increasing or decreasing the blood pressure. Mainly what happens is it's very important for the long-term regulation of the blood pressure.
Right.
And whenever there is a less perfusion or where there is a hypoxia, there are some cells called juxtaglomerular cells in the kidney. They are present in the afferent arterioles of the glomerulus. So these cells, they sense even the sodium concentrations which is sensed by the macula densa. The information is passed to the juxtaglomerular cells and they release a substance called renin. This renin converts a plasma protein called angiotensinogen into angiotensin 1.
Right.
This angiotensin 1 is again, when it is going into the circulation, it is converted by an angiotensin converting enzyme. This enzyme is mostly present in the lungs. It is also present in certain other tissues, mostly in the lungs.
Right.
It converts the angiotensin 1, which is a 10 amino acid peptide, into a decapeptide, which is converted into an octapeptide, that is 8 amino acid, angiotensin 2.
Right.
This angiotensin 2 is very important because that is bringing about a lot of actions which will increase the blood pressure.
Right.
One is this angiotensin 2 is a peripheral vasoconstrictor. So systemic arterioles can constrict because of the angiotensin 2.
Right.
Second one, it also has a direct action on the kidney and it increases the water reabsorption there. In addition to that, more important, it acts on the adrenal cortex. And it causes the secretion of aldosterone. This hormone aldosterone can increase the sodium reabsorption in the renal tubules. Along with sodium, water is also reabsorbed. So the blood volume is increased and BP will be increased. Okay. At the same time, this angiotensin 2, so many actions it is having. So it acts even in the hypothalamus, and posterior pituitary gland releases ADH, antidiuretic hormone. And this also causes water reabsorption in the kidney. So all these together will increase the volume, blood volume in the kidneys. One more action is there. It will stimulate the thirst center in the hypothalamus and make the person drink a lot of water. So all these together increase the BP. Normally what happens is when the BP is increased, the renin secretion will be decreased. But in certain conditions, like suppose there is a renal artery stenosis or some pathological conditions, this mechanism, RAS mechanism is disrupted. Right. So that is one important reason. Then the renin secretion goes on continuing, it is increased and that will increase the blood volume and the reason for edema also, which we see in some cases. So all this is what is affecting, and this mechanism actually is a very good mechanism in the control of BP. For the regulation of BP, if you see, the feedback gain of this RAS mechanism is very high, and when there is a low BP, it is playing a very effective role in raising the BP. That is what is about the RAS mechanism.
Right. Now, since we have covered the normal physiology and the normal blood pressure cutoffs, one more question before moving to others from Madam. Madam, during the BP recording, what are the usual phases? We say that 5 phases are there. If you can
BP
explain on
recording.
that.
Actually, what we are doing is an indirect method. Direct method means it's feasible only in animals. We directly introduce into the cannula and see. But here what we are doing is we are tying in the cuff in the upper arm, and then we are inflating the cuff. What we are doing is actually we are equating the brachial artery pressure with the pressure of air in the cuff and measuring the air pressure with the manometer.
Right.
So here, what we do is by palpatory method. There are 2 methods, palpatory and auscultatory. By palpatory method, we are finding a rough value of the systolic blood pressure.
Right.
And then what we do is we raise a little above this value, 20 or 30 millimeter Hg above this value we raise.
Right.
And then slowly we deflate the cuff. And that time we will keep the stethoscope over the brachial artery in the inner aspect of the elbow.
Right.
Then we will start hearing certain sounds.
Right.
Why these sounds are coming means actually the brachial artery is completely occluded when the cuff is inflated.
Right.
So when you're deflating the cuff, there comes a time when the occlusion is relieved and the blood gushes.
Okay.
So that is producing a turbulence.
Right.
When it reaches more than the critical velocity, there are certain things in physics like Reynolds number,
Yes, ma'am.
rho dV by eta.
Yeah.
So when it exceeds 2000, 2500, you start getting sounds.
Right.
So these are the series of sounds we are hearing when we keep the stethoscope.
Okay.
They are called the Korotkov sounds.
Right.
After Nikolai Korotkov, who found out these series of sounds,
Right.
there are 5 phases
Okay.
in the Korotkov sounds. The phase 1 is actually when the sounds begin. There is turbulence and the sounds begin, and they are short tapping sounds. For 10 millimeter or something, Hg, you will hear the short tapping sounds. Then the sounds changes a little. It's like a murmurish sound. That is phase 2.
Okay.
Then you get little loud tapping and clear sounds. They are also called gong sound. Previously they used to use the gong,
Right.
and it used to produce a good sound. So that is for 10 to 15 millimeter Hg, you get that phase 3.
Okay.
Then it becomes muffled sounds.
Right.
The muffled sounds is phase 4,
Right.
and the disappearance or the silence, the disappearance of the sound is phase 5.
Okay.
Here, one thing is important. Usually, the appearance of the sound, that is phase 1, we take as the systolic blood pressure, and the disappearance of the sound, we take as the diastolic blood pressure.
Right.
But in some cases, like cases like aortic regurgitation, or sometimes when the circulation is very hyperdynamic, or you will hear the sounds even till 10 or 0 millimeter Hg sometimes in severe cases of aortic regurgitation. So that time, you can't take the disappearance, you will take the muffled sounds as the diastolic blood pressure. So these series of sounds are called the Korotkov sounds.
Okay.
And there are 5 phases, as I told you.
Okay, thank you, ma'am. Just extending on the question on the BP measurement to Girish sir. Sir, what are the various methods in which in clinical practice we measure BP, and what are the precautions which we usually need to take?
So before going to that question, we have recorded one video to show how to record the BP of a patient. And before and one more thing, what routinely in our clinical practice is when the patient come to OPD, we'll ask the patient to sit on near to doctor, and we immediately tie the cuff and see the BP. It's actually wrong. At least 30 minutes, patient has to take complete rest on the chair. He should not smoke, he should not take coffee, tea, all these things. These are the prerequisites for the BP recording. And at least 24 hours prior to the BP recording, he should not take alcohol also. Okay, these are the basic things, and patient should not be tensed. Patient should not come after a long walk or running. All these things are required. Then slowly we can, like Madam told, we can tie the BP cuff. Adequate width of the cuff is very important. Then remove the clothing, tie the cuff. Then you can record. That is the basic BP recording by a sphygmomanometer, that is mercury. Okay, and we have other methods in ICU. What we use is we use monitors for that. But the best method is always what we Madam discussed. It is with mercury manometer. But in ICU, we use another method, that is an invasive method. Madam told physiology they teach with animals. But in ICU, we can put an arterial line and we can monitor the BP. That is required only if you require continuous monitoring, like somebody is having a hypertension on vasopressors, you want to monitor minute by minute BP reading. That is needed. Or pheochromocytoma, BP is very high, or somebody is having raised ICP, you want to continuously monitor the BP, then you require an arterial. It has got its own like problems, like arterial spasm can occur, the gangrene can occur, so many complications also there, but that is the best method, because conditions like Madam has told about aortic regurgitation, actually there is no BP there. It is only because of the increased pumping. Or arteriosclerosis, like previously I told, arteriosclerosis is a thickening of the blood vessel. Actually BP is not there. Only because of the thickening you are getting increased BP. All these conditions we can use it, but in our setup, in our country, we cannot use this arterial BP for all patients. Those who are admitting in ICU, you need to have an intensive BP monitoring, then only we put it. Otherwise that is not required. So routinely we all use mercury manometer for checking the BP, that's all. Or other types of electronic devices are there, but they are not accurate. And we have recorded a complete 6-step method how to check the BP that will show along with the video.
Today, we are going to discuss the basic steps that is to be followed in measuring a blood pressure. There are ideally 6 steps that is to be followed in making a proper blood pressure reading. The first and the most important step is preparation of the patient. Then comes the proper technique of BP recording. The third step is measurement of systolic blood pressure and diastolic blood pressure. The fourth step is documentation of these readings. The fifth step is taking the average of the readings. And final step is telling the patient the report both verbally and in writing. So first we come to the first and most important step, that is preparation of the patient. In preparation of the patient should be adequately relaxed, ideally in a sitting position for more than 5 minutes. The patient should not take coffee, any BP medications, or done any exercises prior to the procedure. The patient's bladder should be completely emptied. And also, the patient has not taken any drugs or any medications that affect the BP. And the patient's both arms should be adequately exposed. Then we come to measurement of the blood pressure, the proper technique in assessing the blood pressure. First, the patient's arm should be at a resting position. It should be adequately supported. Then we need to take the BP apparatus. Before that, we need to proper hand wash and then use proper gloves before measuring the patient. So first, the BP apparatus should be checked. It should be adequately calibrated. We need to choose an adequate cuff size for the BP measurement. An adequate cuff size means the bladder encircles the arm 80%. And the ideal position of placing the cuff pressure is the midpoint of the sternum or at the level of the right atrium. So first we need to adequately hand wash, wear gloves, take the consent and check the BP apparatus, it is calibrated. Then you need to support the patient's arm in resting position. Then you need to place and select an adequate cuff size. That is, the bladder size encircles 80% of the arm. And you need to place the cuff such that it is at the midpoint of the sternum at the level of the right atrium. Then we come to the third step, that is measurement of the systolic blood pressure and the diastolic blood pressure. In this step, we try 2 ways. That is, first we will take the palpatory method followed by the auscultatory method. First we come to the palpatory method. In this procedure, first we will palpate the patient's radial artery and we will inflate the cuff gradually. At a point, we should not palpate the pulse, and this point marks approximately to the systolic blood pressure. Then we will gradually deflate at a rate of 2 millimeters of mercury per second. Then we come to the auscultatory method. Here we can use the diaphragm and bell of the stethoscope. So in auscultatory method, we have obtained the systolic blood pressure by the palpatory method. You will increase the cuff pressure 20 to 30 millimeters of mercury above the palpatory method we have obtained, and gradually you will deflate it at a rate of 2 millimeters of mercury per second. So the point which we hear the Corov sound marks the systolic blood pressure, and gradually as you decrease the BP, there is disappearance of the Corov sound and it marks the diastolic blood pressure. So first, initially by palpatory method, we have obtained the systolic blood pressure, and we will increase the blood pressure 20 to 30 millimeters of mercury above that systolic blood pressure. Then we come to the auscultatory method, where we will gradually decrease the blood pressure at a rate of 2 millimeters of mercury per second, and the appearance of Corov sound marks the systolic blood pressure, and the disappearance of Corov sound marks the diastolic blood pressure. So then we come to the documentation and taking the average of these readings. Ideally, we have to take 2 or more recordings at 2 or more occasions apart. And these recordings should be documented, and we need to take average of the document. You need to measure the blood pressure on both the arms at the first visit, and the highest blood pressure should be taken. Then finally, we come to expressing the blood pressure to the patient. You need to convey this message both verbally and also in writing. Thank you.
Yeah, moving on to Dr. Lakshmi. So, can you give a classification of antihypertensives?
Yes. So keep in mind what Madam has told, the seat of control of hypertension. Ma'am mentioned the key role of the renin-angiotensin system. She mentioned the peripheral vascular resistance and the cardiac output. So keeping in mind, we need to block the effects of these systems, and we'll go to the classifications. For renin-angiotensin system, Ma'am mentioned the synthesis. The most commonly used, most effective drugs for control of hypertension, one group is the AC inhibitors of the angiotensin converting enzyme. Examples: ramipril, enalapril. Together with that, we have angiotensin receptor blockers, which block the AT1 type of angiotensin receptors. Losartan, telmisartan are examples of this group. Staying with the RAS system, remember also direct renin inhibitors, the drug called aliskiren. Since renin-angiotensin system, the JG cells are in the kidney, you should also remember the role of the kidney in blood volume regulation. What are the drugs acting on the kidney to affect BP? Diuretics. So the thiazide group of diuretics, hydrochlorothiazide, chlorthalidone, are used in the management of hypertension. Now we'll go on to cardiac output. Which are the drugs directly acting on the heart? Beta blockers. They'll slow the heart rate, reduce the force of contraction, reduce cardiac output. Beta blockers like metoprolol, bisoprolol, nebivolol, that group. Then there is also central sympatholytics. Sympathetic system is also controlled. They are also used in the control of BP. They are alpha-2 agonists, clonidine, alpha-methyl dopa. Then ma'am said peripheral vascular resistance is key. So there are drugs directly causing vasodilatation. Important ones among those are calcium channel blockers, nifedipine, amlodipine, nicardipine group. Then you have alpha blockers. They're prazosin, doxazocin. You have other drugs which are add-on, generally not used first line, but vasodilators like hydralazine, minoxidil, sodium nitroprusside. Those drugs like phenol-dopam, these are all vasodilators. And another add-on that I didn't mention is aldosterone antagonist. Also, you can remember it with the RAS system, spironolactone, eplerenone group. So these are the major drugs for hypertension.
Okay, now we have classified the drugs based upon the more like the mechanism of action, and most of the times we might end up using combinations rather than a single kind of drug while treating hypertension. So if you can say about what are the recommended combinations and what should not be used as combinations. Yeah.
So taking from the classification itself, when you combine drugs, when you give a single drug, it's likely that the body tries to compensate and slowly the effect of that drugs slowly decreases. So when you combine drugs, try to combine drugs with different mechanism of action. Okay. So the first line drugs for BP are AC inhibitor, ARBs, calcium channel blockers, and thiazide diuretics. So when you combine, generally it is safe to combine all these three together. Okay. If you start with the AC inhibitor or ARB, you can add on a calcium channel blocker if BP is not controlled sufficiently. Still not controlled, you can add on a diuretic. Okay. And there is no order like you should first add on this drug or first add that drug. So you can add those on. If still with the three first line drugs it's not controlled, you can add on spironolactone. One advantage is if there is hypokalemia due to thiazide, spironolactone will bring up the potassium. At the same time, we have to remember to check because AC inhibitors also has the side effect. So you can combine, but often there is a certain element of caution that you have to use. And other combinations, you can add beta blockers also if it is not controlled with the first line drugs. Combinations to avoid is clonidine with beta blocker. There, if you give these two, the chance of rebound is very high, and there is no advantage of combining it together. AC inhibitors, ARBs, it's a question that that comes to our mind. Should we combine the two? It is just a sequential block. There's no advantage of combining those two. So we should avoid the combination of AC inhibitors and ARB as well. Then when you are giving beta blockers, older beta blockers or non-selective beta blockers, propranolol, you have to take caution in diabetics. Thiazides also cause hyperglycemia. So when you combine those drugs also, you have to be very cautious. One more combination to avoid is the calcium channel blocker verapamil, which can also be used in hypertension. It has a suppressive effect on AV nodal conduction or atrioventricular conduction. Beta blockers also have the same effect. So that additive block may slow the heart dangerously. So you don't combine it in hypertension. If you are using it for atrial fibrillation or high atrial rate, there it may be beneficial, but not in hypertension. So these are some of the combinations.
Okay. Now, since we have cleared what are the classes of drugs and also what are the possible combinations, I want to Girish sir, from a clinical perspective, what do we usually start as a first line in various conditions, like based upon gender or other comorbidities and things like that? What would be the usual way we treat hypertension?
Here, Dr. Lakshmi has clearly told about uses correctly. We follow the same pattern only while treating the patient. If you are a doctor who graduated 10 years back, the first line drugs were ABCD category. A is AC inhibitor, B is beta blocker, C is calcium channel blocker, D is diuretic. During that time, diuretic was the first choice. And you can, second line, you could use any other drugs. But recently, last year, maybe 2 years back, the guidelines have slightly changed. That is, B is not there, A, C, D guideline. So like doctor told, we can use any of these drugs as first line drugs, or you can use all the drugs during as a first line drug. Like normally when we get a patient who is having hypertension, one of the best option will be starting on AC inhibitor or ARB, because adverse effects are very limited, very rare during treatment of AC inhibitor or ARB. Only problem is patients who like pregnant ladies. These drugs should be avoided. AC and ARB should be avoided in the pregnant lady. Otherwise, this can be used in almost all conditions. But remember, before starting AC or ARB, you have to check the potassium of the patient. You have to check the creatinine of the patient. Pregnancy should be ruled out. If creatinine is very high, you cannot use AC or ARB. If potassium is already very high, better to avoid these drugs. So AC and ARB has got a lot of advantages in starting as a first line drug. So that is one drug. Second drug, what madam told, is calcium channel blockers. Normally we use amlodipine, nifedipine, cilnidipine. These are the routine calcium channel blockers we start. The problem with this calcium channel blocker is rarely patient can have pedal edema. Some of the patients can have tachycardia. That's why madam was already told you can combine beta blocker with calcium channel blocker. The disadvantage of calcium channel blocker is it increases the heart rate. Beta blocker, if you are adding as a second line drug, it can control the heart rate. But very rarely these patients can have pedal edema. If you can counsel the patient and continue the calcium channel blocker, it is better. Suppose the patient is not convinced with your counseling, you can change to some other drug. Diuretic, hydrochlorothiazide we are using as a first line drug. Some patients can have hypokalemia, like madam told. In that case, you can add a potassium sparing diuretic to the regime. Okay, so that can be done. So first line drug will be ACE, ARB, or calcium channel blockers like amlodipine, nifedipine, cilnidipine, all these things, and a diuretic. These are the first line drugs. Beta blockers used as first line drugs only in limited condition. If the patient is having coronary artery disease, patient is having cardiac failure, like that conditions you can use beta blocker as a first line drug. And remember, AC inhibitor and ARB should be avoided in pregnancy, hyperkalemia, and renal failure. Otherwise, these are the first line drugs you use in all conditions. And one more problem is when we start a anti-hypertensive drug for any patient, you have to wait at least 2 weeks to get a result of that, because peak action comes only after that. The problem with routine clinics are every day patient will be coming to check the BP after starting drug. So that anxiety itself can increase the BP. So after 2 weeks you check the BP. Suppose you are not satisfied with your BP control, you can either increase the dose of the drug or add another drug from this combination, 3 combination. Even after 3 first line drugs, if BP is not getting control, you go for second line drug. Unfortunately, now beta blocker has gone to the second line drug. So there is no point in starting beta blocker as a first line drug without a major indication for that. So it is clear, AC inhibitor or ARB, calcium channel blocker or diuretic. These are the 4 categories comes in first line.
One thing which we kind of missed during the discussion was for workup of BP, what are the essential things we need to, like a quick run through if you can give, sir?
So suppose I am sitting in my clinic and seeing a hypertensive patient. When I am seeing the BP, suppose BP is high, I need at least 3 readings before branding that patient as hypertension. So I'll ask the patient to come after 1 week or next 2-3 weeks I'll be taking 2-3 readings. Then I'll confirm that this patient is having hypertension. And again, suppose I have doubt, this may be white coat syndrome, he's coming to hospital getting anxiety and BP is increasing, I can take an ECG. First line of investigation should be always ECG, because if the patient is having high BP which is not getting controlled, persistently it is high, means definitely the ECG may show some changes like LVH pattern. Okay, so ECG is a very important tool in making a diagnosis of hypertension. Right. Then echo, if it is available, you can use to confirm your findings in ECG. If it is not there, it's okay. Then basic investigations, like you have to ask for a blood sugar. So all hypertensive patients, diabetes should be ruled out. Cholesterol should be ruled out, because suppose a patient is having only hypertension and another patient is having hypertension or diabetes, hypertension with dyslipidemia, the risk of coronary vascular disease is almost double. Okay, so if sugar is there, that should be treated well. Cholesterol is there, that should be treated well. Then the third investigation will be creatinine. The elevated creatinine or kidney disease itself can produce high BP, and high BP on long term can produce kidney failure. So creatinine is the third investigation. Then electrolytes. In electrolytes, most important is potassium. Like madam told, potassium can be low in some types of hypertension, like if there is hormonal disturbance like secondary hypertension, Corov syndrome and all, potassium can be low. Or if the patient is already on diuretics, that itself can reduce potassium. One of the advantage of potassium is it itself can reduce the BP. So the hypokalemia can increase the BP. So you have to check the potassium. Then thyroid function test is very important because hypothyroidism and hypertension is like brother and sister. You have hypothyroidism, most of the patients will have hypertension. Okay, so that should be basic investigations are that only. Then suppose you feel that it's a long-term hypertension, fundus examination, eye fundus examination should be done because the basic problem in hypertension is vasculopathy. Blood vessels are involved. So to see that, you have to see the fundus. Okay. Then if the patient, you are suspecting a secondary hypertension, abdominal ultrasound with Doppler study. If the patient develops hypertension after 50 years, Doppler is a must. Then if you have evidence for secondary hypertension only, you need to do a lot of other investigation. Otherwise, basically this is enough to make a proper diagnosis and treat the patient.
Okay, sir. Back to Madam. Madam, you did mention about the peripheral vasculature. So if you can elaborate on the role of peripheral baroreceptors and peripheral vasculature in maintenance of BP once.
When I told about the RAS mechanism, I was telling that it is a long-term mechanism.
Yeah.
So there are some short-term mechanisms in the regulation of blood pressure.
Right.
So these baroreceptors mechanism, that is a reflex mechanism, nervous mechanism. Nervous mechanism means it acts within a fraction of few seconds itself it acts.
Right.
So this is a very important mechanism regarding the baroreceptors in the regulation of BP because moment-to-moment variation. Sometimes when you cough, or when you, even during micturition or some act, there is a variation in your BP. But it has to be immediately adjusted.
Right.
And especially when you change the postures, when you're lying down, when you get up, immediately certain adjustments has to take place to adjust your BP to the normal level. So that is by these peripheral baroreceptors.
Okay.
And these baroreceptors, they are situated in the carotid sinus, which is a dilatation of the internal carotid artery. Just at the beginning, that's the dilatation. And that's the aortic arch. So these are nerve endings. Actually, these receptors are nerve endings only. They are the endings of the 9th nerve and the 10th nerve.
Okay.
9th means glossopharyngeal and the 10th is the vagus. 9th nerve carry the impulses from the carotid sinus. 10th nerve, vagus carries from the aortic arch. The impulses go to the medulla. There are centers in the medulla. The medulla, there are centers called nucleus of Tractus solitarius. From there, the impulses again go to certain areas, like previously the nomenclature was depressor area, pressor area, but nowadays they use the terms caudo-ventrolateral medulla, the austral-ventrolateral medulla. So first it goes to caudo-ventrolateral medulla, it stimulates that area with glutamate as the transmitter. Then the transmitter from caudo-ventrolateral medulla to the rostral-ventromedullary medulla, which is the previous pressor area, that is GABA. It's an inhibitory neurotransmitter. Okay. So whenever there is increased BP, more number of impulses are going through the baroreceptors. When the more number of impulses are going and there is an inhibition of this rostro-ventrolateral medulla, which is concerned with the sympathetic action. Mainly from there, projections go to the intermediolateral horn in the spinal cord from where the sympathetics are originating. The heart is supplied from T1 to T5 segments of the spinal cord. The intermediolateral horn gives the sympathetic nerves. They form a plexus and they are supplying the heart. And whenever the sympathetics are stimulated, it will increase the heart rate, conductivity, everything is increased by the sympathetic. So here what happens, mainly it will act on the vessels also, because this pressor area is having a response on the diameter of the blood vessels, very important in the regulation of the peripheral resistance. Okay. And the seat of the peripheral resistance is in the arterioles. Okay. Arterioles are the ones which are having a lot of smooth muscles and it can adjust the caliber very much. So from here, the impulses go and because it is inhibited now, there is vasodilatation of the blood vessels. Okay. And also sympathetics are reduced, the activity is reduced, so heart rate will reduce. Whenever heart rate reduces, because heart rate and stroke volume determines the cardiac output. Heart rate into stroke volume is cardiac output. So cardiac output will reduce. So both these factors, when cardiac output as well as peripheral resistance are decreasing, they will decrease the BP. This happens when there is an increased BP. Same thing, when there is a decreased BP, what happens is less number of impulses go. So when less number of impulses goes, everything, it happens in the opposite way. So the pressure response is increased now because there is less inhibition of the rostroventrolateral medulla. So this will increase the peripheral resistance and cardiac output and increase BP. This is how the BP is getting normally adjusted.
Okay.
But there is one more center, cardio-inhibitory center in the medulla. This doesn't regulate the peripheral resistance at all. It only determines the heart rate because it is made of the dorsal nucleus of vagus and nucleus ambiguous. These have action. The parasympathetic, the vagus supply the heart. Right vagus and the left vagus are the ones which are supplying the heart, and they reduce the heart rate when they are stimulated, whenever they are stimulated. So when there's high BP, they are stimulated, so that will reduce the heart rate. So that action reduces the cardiac output and it will decrease the BP. So this is the mechanism which regulates BP. But in a person with chronic hypertension, when the BP is at a higher level, then what happens? Why doesn't this mechanism act? That is a question which comes in our mind.
Right.
So here the baroreceptor reflex, always they have a range, 60 to 180, and sometimes even from 50 to 200 it can act. In that range, this baroreceptor reflex will act very well. But in chronic hypertensives, if the blood pressure remains high for a period of time, like 2 or 3 days, these baroreceptor reflex, they are set at a higher level. So they don't function for the normal range of the blood pressure. So they are set at a higher level, so they don't imply for these type of patients. That is the mechanism.
Okay, thank you, ma'am. So coming back to Girish sir, so we have discussed mostly about the outpatient management in hypertension, but in ER something of more concern will be hypertensive emergencies and urgencies. If you can tell what it is and how do you manage it?
Hypertensive emergency and urgency both are almost equal. Only thing is a slight variation in the definition. Okay, emergency means end organ damage is also associated with a high BP. Okay, high BP, if you search different guidelines, different books, they might have written 200, 120, 180, 120, 220 by 120. Various guidelines says different types of BP. Stock guideline, if you see, that's a different BP. Myocardial infarction, it's a different BP. Whatever it is, end organ damage is associated with high BP, then it is emergency. Okay. Otherwise, it is urgency. Whatever it is, we have to control the BP. Only problem is, some conditions, our control should be slow. Some conditions, our control should be fast. For example, patient is having pulmonary edema with high BP. Unless until you control the pulmonary edema or hypertension, you have to control both. So you control, suppose patient is having cardiac failure with pulmonary edema, high BP. If you don't control the BP, pulmonary edema is not going to come down. So there it's a very urgent condition. You have to reduce the BP within 1 hour or 2 hours by giving some IV infusions. Like hemorrhagic stroke, there also you have to control the BP very fast. Okay, patient who is having high BP with tachyarrhythmias, you have to control the BP and heart rate very fast. Other conditions like a patient who is having a stroke, who is having high BP, slightly higher BP like 180 by 110, that may be a mechanism to prevent the damage of the ischemic penumbra. So you should know what is the scenario, then only we can control the BP. Some condition we need to reduce the BP drastically to a normal level, like patient is having pulmonary edema, you have to control the BP very fast. Like conditions like preeclampsia, eclampsia, there also you have to control the BP very fast, but unfortunately, unless until you take the patient for delivery, this is not going to get controlled. So there, that is the end point of the BP. So that difference is always there. One condition, BP is very high, end organ damage is there, that is hypertensive emergency. Other condition, high BP, but there is no end organ damage. So what are these end organ damages? Like I told, pulmonary edema is one end organ damage. Hypertensive encephalopathy, patient is having altered behavior, seizure, all these things, it's an encephalopathy. Okay. Renal failure, patient is having acute renal failure and patient is having high BP, that is also end organ damage. Basically what we should understand is both this hypertension and diabetes, they all act on your blood vessel and they destroy the blood vessel, and ultimately what happens, these all blood vessels, small supply to various organs are getting damaged. Like if you have a chronic hypertension, you can see the fundus there, you can see the arteries, you can see the arterial changes. Same type of changes are going to occur in your kidneys, in your heart, in your brain, everywhere. So that eventually that will produce whenever there is a high BP, that can rupture or it can get blocked and can have ischemia or infarction or bleed, whatever it is, that will go to emergency. If that is not happening, on visually we are not seeing, but internally it is happening. So that is a basic difference between emergency and urgency. Once you understand that, you know how to reduce the BP. Some condition you need a faster reduction, some condition you need to reduce the BP by 24 hours, that is enough. So which all the drugs that we can use, that is also very important. So previously we used to give hydralazine. When we had injection hydralazine, that was one of the first line drugs we used to use in these type of conditions. But now we don't have IV hydralazine, so we almost all conditions who is having an hypertensive emergency, labetalol is one of the drug of choice now we are using. But IV labetalol is one of the condition. One of the drug we use in almost all conditions. But one condition like a patient who is having pulmonary edema and hypertensive emergency and cardiac failure, associated cardiac failure, hypertension, pulmonary edema. There, when we are using beta blocker, we have to be very cautious, because beta blocker acutely it can suppress the myocardial contraction. So the better drug there it will be this NTG infusion. So that is the only condition NTG has got a edge over beta labetalol. So all other conditions you can use safely beta blockers, including pheochromocytoma, because pheochromocytoma, one of the problem is you have to start alpha blocker, then only you can start beta blocker. But fortunately, labetalol has got both alpha blocker and beta blocking activity. Even then, you may have to add at least one alpha blocker along with labetalol. Otherwise, almost all conditions you can use labetalol, except in patient who is having cardiac failure, you go for NTG infusion. Sodium nitroprusside nowadays we rarely use because of its side effects and difficulty in using the drug. All these things are there. Labetalol will be one of the best drug which can be used in emergency room.
Thank you, sir. Coming to Dr. Lakshmi, we did mention about the various drugs which are available to treat. So what are the adverse effects one need to monitor when a patient is on antihypertensives?
So whenever you have a pharmacological effect, there will be some extension of the effect beyond what you desire. So hypotension is something you can consider. So do all the antihypertensive commonly cause hypotension? Luckily, not all of them seriously cause hypotension. When you talk about AC inhibitors, if the patient had a high renin level, if their volume depleted, their renin level may be high. Younger patients, their renin level may be high. In such cases, there is some first dose hypotension, especially in captopril, the first AC inhibitor use. So there is a first dose hypotension which you manage by giving the drug at low dose, starting it at low dose, giving it at night. Other groups that can cause hypotension especially are alpha blockers, the vasodilators. So they can cause postural hypotension or orthostatic hypotension and first dose hypotension because of the vasodilatory effect, both venous and arterial, pooling orthostatic hypotension. So these two are more notorious to cause hypotension. Then you can look at vasodilators as a group. What are the group side effects? Vasodilator, ma'am had explained about reflex mechanism. There can be a reflex tachycardia. Then all vasodilators, they'll tend to cause a little headache, and the reflex tachycardia will manifest as palpitations. These are effects of all vasodilators. Then rebound hypertension is something that you have to educate the patient about, especially if you're putting them on beta blockers, and in resistant hypertension if you're adding clonidine. It's very important to explain to them that if you're going to stop this drug, the BP is going to shoot up to dangerous levels. So especially clonidine and beta blockers, you have to explain this. Then going specifically to AC inhibitors, ARBs. AC inhibitors, they are known to cause cough in about 10 to 15% patients. So in those patients, if they come back with cough, you would change it to ARBs. That's because the reason for the cough is that ACE is the enzyme that breaks down bradykinin. So if you block ACE, more bradykinin levels cause cough, and also angioedema can be seen with AC inhibitors, which is not present for ARBs. The remaining adverse effects of this group are rash, hyperkalemia, the phytotoxic potential or the teratogenicity. These are common to AC inhibitors, ARBs and aliskiren. Some blood dyscrasias have been seen with AC inhibitors too, and altered taste sensation or dysgeusia. Coming to beta blockers, other than this rebound hypertension, some altered nightmares, such complaints also come from patients. CCB's a particular class side effect is pedal edema. Calcium channel blockers cause pedal edema. Thiazide diuretics, metabolic side effects are seen. Some loss of diabetic control, hyperlipidemia, hyperuricemia, and electrolyte abnormalities, hypokalemia, hyponatremia are also seen. These are the common side effects of the drugs we are using the most.
Thank you. So we are done with the pre-prepared questions, the last round, starting with Madam. So Madam, I think we have covered most of the relevant questions under this topic. But if at all I have missed anything, can you just elaborate on what are the expected questions for undergraduate students from the topic of hypertension? Ma'am.
So actually, all definitions will be asked in the blood pressure chapter and with hypertension. So they will ask even what is pulse pressure that we have not discussed. It is the difference between systolic and diastolic blood pressure that is called the pulse pressure. Then there is something called mean arterial pressure. Actually, it is not the arithmetic mean here, but actually it is a diastolic pressure plus 1/3 pulse pressure. Why we are taking like this is because of the cardiac cycle. The duration of ventricular systole is only 0.3 second, whereas diastole is longer duration, 0.5 second. So we can't take the arithmetic mean. So a standard deviation is plotted and they have derived with this formula. So that also usually we ask in the exam. Then factors maintaining BP, what I discussed last, the determinants, they are called the determinants of blood pressure. That is an important question. Then factors affecting BP like AETCM, gravity, so many other factors also have an effect on BP. That is also asked for them. Factors affecting BP. Even the child, there's a difference. And adult, there's a difference in the normal blood pressure. So those are asked. Then regulation of BP is a very important question. Short-term regulation is there, long-term regulation. Short-term, we have discussed baroreceptor reflex. There is another one reflex called chemoreceptor, chemical regulation of peripheral receptors. So there what happens is when the PO2 is less or PCO2 is increased, these receptors are stimulated and they will bring an increase in the peripheral resistance. There also the peripheral vasculature is the one which is most affected. It will increase peripheral resistance and it will increase BP. But it comes only when the BP is falling below 70. When the mean blood pressure falls below 70, only chemoreceptor reflex comes. That is asked in the exam for them. Then there is one reflex called CNS ischemic response. In an emergency, very dire emergency, when the patient's BP is falling without traffic accident or something, when it's falling below 40, that is an emergency situation. There what happens is, this vasomotor center I told you in the brain, which contains the rostral, ventrolateral medulla, caudal ventrolateral, it is directly stimulated by the carbon dioxide in the brain. So you don't have the nerves carrying the impulses here. Direct stimulation of the vasomotor center, which is causing a very drastic peripheral resistance increase, because all the blood vessels constrict and try to push the blood to the brain and heart, the vital organs. Mm-hmm. So that is a CNS ischemic response, and that is asked usually. Mm-hmm. Then long-term mechanisms are there. The renal body fluid mechanism is there by adjusting the filtration in the kidney. Okay. It works. And then the DAS mechanism. And hypertension also we ask in physiology sometimes. Okay. Basics like right. The types of hypertension, essential and secondary hypertension. Okay. Those are the questions.
Thank you. Same question, Dr. Lakshmi.
Pharmacology also generally classification of antihypertensives, the first line drugs in detail, central sympatholytics also in detail. They may be asked to choose between two drugs given a particular clinical condition. Then drugs safe in pregnancy and management of hypertensive emergency, urgency are also commonly asked questions.
Okay. Sir?
One important question is classification of hypertension from medicine point of view. That is very important. Then classification of drugs, that same thing Madam has told. Both in pharmacology and medicine they ask classification of drugs. Each drug in detail also they can be asked, like beta blockers in hypertensive patient, like that they can ask. Investigations in a hypertensive patient is another major question. And most of the question papers repeatedly asking question is always this hypertensive emergency and urgency management in ER. Okay, that is seen in many question papers across India. So many universities that questions are repeated.
Thank you, sir, and thank you all for this such a dynamic and informative discussion. Thank you.